So what I plan to do is do a little bit of an introduction to health literacy itself, and then what we've done within the team is kind of selected a published paper that has explored health literacy in transgender and non-binary communities, and then also discuss how we can measure health literacy in our work that we do. But before I start, you'll notice the acronym TNB that will be used throughout this presentation. The reason we've used this here today is because it was used within the published paper. So to be consistent with those findings, we're using it here as well. So just wanted to highlight that before we get started. And before we go into the actual kind of work that we're going to be discussing today, I just wanted to pop up the slide that was shared by the Pride Well Summit project team, and you'll see this throughout the conference this month. And it's just a reminder that we want all our events to be safe places for everyone to learn and to share and to grow. So the approach that we expect from our host and all our attendees is to please respect one another, to be empathetic, and by acknowledging the feelings and experiences and identities of those around us. So please be caring by creating a non-judgmental space for people to be authentic. That's really important throughout these sessions. They're all sessions, but particularly the sessions that we're going to be hosting this month. We want to be supportive by listening and empowering and supporting one another to be inclusive and to include, so we want to include all LGBTQ plus identities and experiences, ensuring that we actively create inclusive spaces for seldom heard people within the community and to be heard and to be seen. And just as a reminder that we are recording the sessions and they'll be shared on our YouTube account in the future. Thank you. Is there anything else that you wanted to add, Bradley, before we get started?
No, that's everything, but I will be in the chat. So if there is any questions coming in, do put them in and I will highlight them to Aisha as she's presenting.
Brilliant. Thank you. So before we get started, let's talk a little bit about health literacy in general. So what is health literacy? There are close links between health literacy and behavioural science, and behavioural science theories, models and toolkits can impact on people's health behaviours by allowing them to understand why those behaviours are important. So improving the level of health literacy amongst communities can lead to changing behaviour, for example, in reducing alcohol intake, physical activity and smoking. So health literacy is about individuals' ability to understand and use information to make decisions about their health. It's about people having enough knowledge, understanding, skills and confidence to use health information, to be active partners in their care. So being health literate allows individuals to access and apply health information. It is vital, so it's vital that individuals understand the information that is provided to them in healthcare professional settings, in letters, just to enable them to be an active part of their own health decision making that impacts their health behaviours. So having low health literacy interacts with having a limited English proficiency. And we know that, so this refers to someone who their primary language is not English. So someone who has difficulty communicating effectively in English. What this means is that it can have a significant impact on communication, conversations, or understanding, and as a result, the use of information as a part of the decision making. So you hopefully see why it's really important for health literacy among communities as it can lead to behaviour change. So in terms of the national context, in England, 43% of adults, so that's in the age brackets of 18 to 65, do not have adequate literacy skills to routinely understand health information, and 61% of adults do not have the adequate numeracy skills to routinely understand health information. Evidence has suggested that health literacy is related to an individual social circumstance, as we might imagine. So having good education can be found to strongly protect good health literacy, and individuals with limited financial and social resources are more likely to have a limited health literacy. Low health literacy is an inequality issue which limits opportunities for vulnerable and disadvantaged groups to be involved in decisions regarding their own health. So thinking more about our local context, local context, in Birmingham, over 56% of residents between the ages of 16 and 64 are estimated to be below the threshold of low health literacy. So this means that over 641,000 of residents do not have adequate skills to understand health information, which means they'll be struggling to know how to use and act on this information or any health information that is provided to them. So what are the benefits of health literacy? There are a number of benefits as it can increase health knowledge, excuse me, build resilience, and as a result, encourage positive lifestyle change and empower communities to effectively manage their health. So here are some examples of the impact of improving health literacy. So we can navigate health services, attending appointments, so knowing what to bring, what to expect, and any associated instructions that may come with that. Understanding why they need help, so who to contact and when to contact them, and the ability to communicate effectively with healthcare professionals. So some of these things we may take for granted, but actually there can be such a significant barrier in being able to manage our own health decisions, understanding what the protocols are, understanding what the process is when managing our health. So hopefully I've been able to demonstrate any kind of what health literacy is and why it's important and what the local context is. Before I move on to the next section of the presentation, are there any questions or anything that wants to highlight at the moment? I will continue on then. So as I mentioned, within the team, we decided to bring a paper to discuss here today. So I just want to highlight that there isn't a lot of published work in the UK looking at health literacy in LGBTQ+ communities. So that's something that we need, that needs to be acknowledged today. We recognise that, but equally we want to highlight where work has been conducted and what the implications of the findings are, and what we can and how we can use that in our own kind of day-to-day as well in our work here in public health. So the title of the paper is we are doing the absolute most that we can, and no one is listening. So it's looking at barriers and facilitators of health literacy within transgender and non-binary communities, and this is by Hostetter and colleagues, which was published in 2022. So a little bit of context before we walk through this study. Transgender and non-binary people are individuals whose gender does not match with their sex assigned at birth, and includes people who identify as men, masculine, women, feminine, as well as identities outside of the gender binary, such as non-binary, genderqueer, bigender, or agender. So this study researched transgender, non-binary individuals living in Colorado in the United States of America. So as of 2016, there were approximately 1.4 million people, so around 0.6% of the population in the United States, who identified as transgender and non-binary. This is likely an underestimation in reporting because of the high levels of discrimination and violence directed towards transgender non-binary people. Transgender non-binary people can experience many significant barriers accessing appropriate healthcare, including having doctors refuse to treat them. So these healthcare access barriers can exacerbate already significant health disparities that are experienced in these communities. Transgender and non-binary people have higher rates of diabetes, heart disease, and substance abuse, HIV, and self-harm, and those where gender identity corresponds with sex, than those with gender identity that responds with sex registered for them at birth. So highlighting that there are already significant health areas of concern that we want to interact for these communities, but demonstrating that it's not always easy accessing care. So looking at the research rationale, so we know that increasing health literacy in marginalised communities can lead to reduced health inequalities. But despite poor healthcare access and health outcomes among transgender non-binary individuals, research has yet to address health literacy in this population. So this is one of the first studies that addresses this gap. So this study sought to identify the primary barriers and facilitators to healthcare access and health literacy among a sample of transgender and non-binary people living in Colorado. Colorado is an interesting area as it represents a mix of urban and rural regions, as well as socio-political diversity. So in terms of the methods for this study, participants were recruited through statewide LGBTQ advocacy organisations, posts on social media, leaflets, and those who were interested made contact. To be eligible to participate in the studies, individuals had to identify as transgender, non-binary, or gender diverse, be 18 years or older, and live in the state of Colorado. So in-person qualitative focus groups were conducted throughout the summer of 2019. So that we had 6 face-to-face, and the 7th focus group was held online at the start of 2020 to accommodate those who wished to participate but unable to attend any person groups. There were 5 primary questions that were asked of participants. So it was regarding their experiences finding and using healthcare information and services. Participants were asked where they found healthcare information, what they wished providers knew in order to provide quality healthcare services to transgender and non-binary individuals, what an ideal healthcare system designed to serve transgender and non-binary individuals would include, and what the impact their experiences within the healthcare providers and system as transgender non-binary individuals had on their health. And finally, what would help transgender and non-binary individuals more effectively navigate through the healthcare system. So participants were 46 self-identified transgender or non-binary individuals living in Colorado. Their age ranged from 19 to 72. The majority reported as white Caucasian, but a representation also from the Hispanic, Asian, Native American, and also more than one race and ethnicity communities. When asked their gender identity, 23 participants reported being transfeminine, 12 reported being transmasculine, 9 reported being non-binary, and 2 reported another gender identity. So we can see we've got a very good diverse kind of representation in terms of age, ethnicity, gender and sexual orientation there as well. So the authors identified 2 main themes with various sub-themes underneath, but reporting on the findings. So theme 1 was barriers to accessing care, and theme 2 is facilitators to accessing care. So for barriers to accessing care, and sub-themes included difficulty identifying care that was knowledgeable in transgender and non-binary individuals, and difficulties physically accessing care, such as not having reliable transportation, needing to travel far distances, and experiencing long wait times to see transgender and non-binary affirming provider. So it's worth mentioning as well, and just highlighting that healthcare in the United States is largely provided by private sector healthcare facilities and paid for by a combination of public programs, private insurance, and out-of-pocket payments. So for many participants, not having insurance was a big barrier, and for those that did, their plans often did not cover gender-affirming care. A further barrier included negative experiences with healthcare providers and staff. So this included limited knowledge of transgender and non-binary, the impact and the other providers focused solely on their identities, so removing any opportunity to discuss health in general or other medical needs. Participants also discussed that forms and processes were often exclusionary, as they either did not have anywhere to indicate being transgender or only included binary options. These themes highlight some of the ways in which institutional resources can impact the ability to access an appropriate care despite own health capabilities and knowledge. So here we have examples of individuals where their health literacy, is pretty good, but it's not corresponding with the care that they are receiving. We also here have provided some quotations to demonstrate the qualitative data from participant voices. So one individual highlighted that the insurance company did not have a list of doctors, so they had to call around 60 doctors themselves. And then only 2 were identified as potentials, but they had no prior experience of caring for transgender or non-binary patients. Another individual spoke about their experience of their healthcare professional being uneducated on being transgender and having quite a difficult conversation. These quotes highlight a few of the quotations provided by authors, but I would encourage to go reading the published article itself, and it's got a lot more detail and a lot more detail and that demonstrate experiences that these communities face. However, there were also positive experiences that encouraged accessing care. So a significant contributor for accessing care was feeling like their needs were being met. So having positive interactions with medical staff and providers and feeling heard and respected, and that the healthcare provider was invested in their care. Some also mentioned how their healthcare provider worked collaboratively with them and accepted input and feedback. So exactly the kind of environment we want to promote health literacy. A collaborative approach meant that transgender non-binary individuals no longer felt like they had to have all the answers about their care, but had a practitioner that was working with them and educating themselves. So this included medical staff doing research on medication and getting back to them, meaning more transparent conversations about treatment plans moving forward. And having inclusive forms and processes that were inclusive of the gender, names, and pronouns. And to demonstrate this, I've also included further quotations from participant voices. So one participant described how their physician treats them like an informed participant and open to trying new things. Another individual described that their doctor respected their body and how this individual viewed their body, which was nice, and simply being treated the way they want to be treated. So healthcare professionals knowing the language, making this a key reason for accessing care for that at that provider. So although transgender non-binary participants in this study self-reported high levels of capability of health literacy, so for example, knowledge of gender-affirming treatments, skills to find healthcare information, and so on, many were still unable to access affirming care because of barriers. So for example, low levels of provider knowledge of transgender and non-binary individuals' health, difficulty locating affirming care, exclusionary forms, and financial and insurance difficulties limiting the extent to which transgender non-binary individuals were able to use their health knowledge to receive quality care. Individuals had more positive experience where they had access to knowledgeable and collaborative providers that used inclusive forms and languages. And these findings align with the previous work suggesting that an increase in access to care and providers that are knowledgeable in transgender non-binary may also increase individuals' ability to be healthy. So some of the implications from these findings. So they highlight the importance to ensure that healthcare professionals are trained on transgender, non-binary and affirming care, and the impact that this can have on an individual's experience of accessing healthcare. So findings highlight the impact that using the correct names and pronouns, both on intake forms and in person-to-person interactions, can have, ensuring that patients are asked what language they feel most comfortable with, and being an advocate for policy changes for inclusive language in consultations and forms, simplifying the process by applying of a name in marker changes and ensuring that insurance policies include transgender and non-binary health needs. So, as I mentioned, that this study was exploring health literacy in transgender non-binary people, and it was conducted in the USA. So in order to support data gathering, we encourage our local organizations to collect data from LGBTQ+ to demonstrate the baseline of health literacy in this cohort. So measuring the impact of what we do helps us demonstrate that what we're doing is making a difference. So this will help us demonstrate that an intervention is having an impact in a measurable way rather than just using theories. So we're going to talk a little bit about a standardized tool that we've talked about previously in public health as well, to measure health literacy, and this will allow us to this could allow us to compare different interventions or kind of have, as I say, that baseline data here more locally. So we're trying to improve that kind of data capture in Birmingham and UK in general. So this is the all aspects of health literacy scale. So it's got 13 items on it. It's a standardized questionnaire, which has been used in different communities, especially in Tower Hamlets in London, and it's got 4 different facets in it. It is a self-report tool, so it can be completed, by the individual themselves, with pen and paper or online, and it is a validated tool. So what does the toolkit measure? So it helps identify gaps in understanding of health information among individuals or communities, how well people can communicate with healthcare professionals. It gauges an individual's ability to make decisions about their health, and how health literacy influences lifestyle choices, adherence to medication, engagement in preventative care, as well as correlate with poorer health outcomes. So this allows professionals to tailor information effectively, improve communication between service users, and ensure better health outcomes by empowering people to make informed decisions about their health. So what are we aiming to measure in this scale? So this is designed to comprehensively measure various dimensions of health literacy. So it assesses individuals or populations' proficiency in multiple areas. So the 4 different factors that it explores correspond to skills in using written health information, communicating with healthcare providers, health information management, and appraisal, assertion of individual autonomy with regard to health. So functional health literacy is one of the areas, the topics that's included in the measure, and this is the ability to understand and apply basic health information to make appropriate health decisions. Communicative health literacy, so it's the capacity of effectively communicating and interacting with healthcare professionals, asking questions, actively participating in healthcare discussions, and critical health literacy, which looks at skills in analysing and evaluating health information, understanding the implications, and making informed judgments about health-related issues. And the final topic is empowerment. So this gauges an individual's or community's sense of control, confidence, and ability to take action regarding their health. So how do we use the tool? So this tool was developed to be used in primary care settings, for example, GP clinics. So therefore the wording is a bit clinical. It's generally advised not to change the wording on validated tools, but in the absence of an alternative tool, you may wish to change specific words such as patient, to make it more relevant to the work that you're doing, to make it more relevant to, for example, service users. It doesn't take very long to complete. It takes about 7 minutes, and it can be longer or shorter depending on the individual. And the tool is delivered in English, but you may wish to translate into different languages to meet your community group needs. We recommend finding a quiet and private area to complete the toolkit. So some of the questions can be quite personal, and we will also need to ensure that it's all kept confidential. Some may wish to complete the tool on their own, or some may prefer that you sit and read it out loud and let them complete it on their behalf. So there are some risks to and issues to consider when using the tool. In addition, thinking, so for example, people don't always answer truthfully, so they may respond in a way that they think that you want them to respond. The items on the questionnaire do ask questions that may be upsetting or trigger emotions. So for example, in context of the study that we've just talked about, so if someone's had a bad experience and an individual does become upset, please do stop completing the tool and offer them support based on your organisation policies. For example, it could be an employee assistance programme or health and wellbeing support or national wellbeing charities that you can signpost them to. Specifically for any of our external partners, please ensure that you've updated GDPR and Data Protection Act 2018 policies in place. We advise to try and have a go at completing the toolkit yourself and answer the questions based on your experience and see if there's any barriers there that communities or service users may experience. There is some information on how to score and what we're trying to achieve, and I can get that information to anybody who wants a bit more information after this presentation. So here we have I've put some additional links, and so I've put the link to the toolkit that I've just discussed, a link to the paper, and then some other references for health literacy in general. So please do look at that in your own time. Overall recommendations. I think hopefully I've highlighted that the importance of health literacy, and particularly in this community. So we'd like to replicate, the study for having more generalized findings in the UK, and being more allow us to make more culturally appropriate implications. To include a more robust form of assessing health literacy. So, for example, including the health literacy toolkit in your kind of day-to-day to allow us to measure health literacy amongst our communities here in Birmingham. Supporting healthcare professionals in knowledge and confidence to provide transgender and non-binary inclusive care. And this can be done by upskilling healthcare professionals on health literacy and understanding the impact that this can have on care. So here is a slide for the different events that will be taking place this month, and also an evaluation for the session itself. So I'm going to stop there if that's okay, but I'm happy to take some questions or comments.
Brilliant, thank you, Isa. So there's a couple of comments in the chat. So one, for those who are interested in finding out more around health literacy in the context of public health, Justin has put a link there. But there is a bit of a question for us to explore, and open to the room. So much of the evidence on trans and non-binary individuals' health issues and needs focuses on the ability to navigate complex pathways of gender identity services. Do you think that we should be considering health literacy more broadly for these communities in areas like cancer screening and immunisation? And then Justin's also put a link to the community health profiles, which is a session later in the month specifically focused on the community health profiles. Yeah, do you have any thoughts or insight on that?
Could you just repeat the beginning of that? Sorry, I lost you there a little bit.
No, that's fine. So yeah, much of the evidence on trans and non-binary individuals' health issues and needs focus on the ability to navigate the complex pathways of gender identity services. And we know that gender identity services are very much to do with postcode lottery as well, because lots of areas that find it quite difficult to access them. For instance, we heard in the launch event, the nearest one for Birmingham residents would be Nottingham. Do you think that we should be considering health literacy in a more broadly when we're communicating communities, particularly in areas like cancer screening and immunisation?
Yeah, I think there's a lot of work to be done. Yeah, I think definitely by just having a health literate approach in any kind of organisation, any kind of area we're doing, we're likely to be able to not just impact the cohort that we're maybe, for example, hoping to address. So, for example, if you're working with transgender, non-binary communities in mind, we'd be able to kind of reach further than that as well outside of that. So I think it's good practice. I think thinking about from whatever area that we're coming from, to kind of have that health literacy in mind. So even when I was preparing these slides, it's about kind of reducing that jargon, the simple things that we can do, and you have to kind of double check, is this kind of applying health literacy kind of context itself, and kind of thinking that approach. So we can do that anyway in the work that we're doing every day. So absolutely, I think it can go further than that. We can have a wider reach, but there is a lot of work to be done, and I think it's really great here. I mean, I've only been at Birmingham for a short while, but it's great that I think that this health literacy kind of work stream exists, which is really great in terms of that link to behavioural science, and kind of having those kind of links with them or local organisations, and kind of thinking about how we can improve that approach and kind of collect that data. But yeah, there is a lot to be done, definitely. But happy to kind of hear from colleagues on the call as well, kind of their thoughts on that.
Okay, so I'll bring in David next.
Yeah, I think it's maybe a little too specific, my question, or I guess we'll see. It's about using this toolkit. I think potentially there's an issue specifically related to GDPR in that because so few of the population do identify as trans, when we want to publish anything about the data that we've collected, often there's a general rule of thumb that, particularly for protected characteristics, we shouldn't publish anything less than 5 for any. So even if it's the entire consultation that we perform, if there's less than 5 trans people that respond, we can't sort of publish that. I wonder if, I guess, I mean, it's still obviously useful internally, but I wonder if there's any thoughts, perhaps more widely here, about how to overcome that and prevent people feeling like they're being erased because they're small in the face of, because their sort of population is so small in the face of GDPR. Sorry if that's perhaps beyond the scope of this talk.
That's a really interesting question. I know we that is, especially in kind of public health, we deal with a lot of data, and that's definitely something that that we have to consider. I guess, yeah, you're right. There's still that kind of intel that you get internally, which is great. So you can kind of still have that information and hopefully use that to influence your day-to-day practice within your organizations. I guess it's about kind of having the open. I mean, I don't know what, this isn't the answer for it, but I guess I would just be thinking, off the top of my head, I would be thinking, having those conversations with those individuals who are supporting you in a consultation, what their views are about sharing their information, and then having that wider discussion with the organization, what we can do to still get, how we can still use that data in some way to be able to get it out there. Because, like I say, we haven't got a lot of information that is published, but does it mean that we're not able to use that information? I don't know if you have any thoughts on that, Bradley.
Yeah, I mean, I think Justin wants to come in as well, and he's put the comments in the chat. I think it's the way that we present data and the way that we publish data. I think sometimes we can potentially get very hung up on our quantitative approach, but then for populations where we know they are, potentially smaller, or there's going to be less uptake in that type of data published, we can look at doing stuff like case studies, being able to get lived experiences, qualitative experiences. The seldom heard conversation that we did across populations in the physical activity and food and in a few areas in public health was really insightful, particularly for the LGBTQ plus community, but also for the Roman traveller community and other communities that we know we don't necessarily get really big numbers. It makes it difficult to publish in that sense without making it very specific to a population and where they are. But we could find out more about their experiences, their challenges, the information from their groups and populations that help to inform our services, but also what we was doing in the council generally, because the publication went out to a lot of the Health and Wellbeing Board members. And I think it's similar to what we've seen with the community healthcare profiles, that those kind of mixing from the local data that we had, the case study information, but then the national and international data helped to kind of steer a lot of that when it was very difficult to kind of pull out the small populations within Birmingham itself. Justin?
Yeah, thanks. So I mean, I think 2 things. One is GDPR does not require us not to publish data. It requires us to think carefully about whether an individual is identifiable from the data. And I think sometimes we overthink or run away from presenting data because of GDPR and the kind of the assumption of what it is, rather than actually what the kind of regulations say. And it is possible to publish data where you have less than 5 in a group, but you have to do it in a way which says this represents a sample size less than 5, because you in effect, the statistical validity of that sample is less than if that group has 35 people in it, and that's because it's biased. So you could have 4 people with very extreme views, and that skews your sample. And that's always going to be the challenge when we're working with communities that both are harder to reach in terms of sometimes they don't engage with communities. And linking back to issue your presentation, health literacy, one of the big challenges we have with trans and non-binary communities is to build trust. Yeah, and it's one of those core pillars of health literacy, is that if you don't trust that your healthcare professional is going to treat you in a way that is not discriminatory, or is going to, completely obsess about your gender identity and ignore the fact that you've broken your arm. And I remember many, many years ago being shown a letter by one of my trans colleagues to an orthopedic surgeon from a GP, which started, "Dear Mr. Whatever, please see this 35-year-old trans woman who has carpal tunnel syndrome secondary to a wrist fracture." And then had 3 paragraphs about her gender identity treatment, hormone history and everything else, and then said, "Please see and do the needful." So the issue that the patient was presenting with was their wrist. What the letter had focused on completely was their trans identity. And I think, just bringing us back to the kind of discussion, one of the issues I think in the health literacy space is that we have to do a lot to rebuild trust. And if we rebuild trust with these communities, more members will take part in surveys, and then we won't end up with less than 5 people responding, and then we won't have to worry about GDPR. So it's a kind of virtuous circle. While I'm on mic, though, if I can just ask Isha a slightly different question that I put in the chat. Isha, obviously, you're relatively new to the behavioural science team, but in preparing for this presentation, I suppose my question is, how personally for you and the behavioural science team do you think doing this is going to change the way you practice behavioural science and how you approach some of the things that we're doing as a public health department moving forward, thinking about the trans community? Can you share a bit about how this has changed your thinking, opened you up, or was this an area you knew a lot about before?
Yeah, thanks, Justin. So yeah, relatively new to the team. And relatively new to kind of exploring health literacy as well. So it's a really interesting kind of approach, and really already seeing the impact that it can have on our general local residents in Birmingham. In terms of this topic area, so my background's in sexual health research. So from that perspective, I've kind of been involved in thinking about, diversity and inclusion, and, how sexual health messages are getting out there and that kind of thing. So in terms of that, I've had some experience with, but in terms of not as much as I would like. And I think that's something in my preparation for this session, I didn't take it lightly. I wanted to make sure, just having those conversations with Bradley, having those conversations with Joe and Shnar within the team, and making sure that it's a sensible approach. And I really like that, for example, that first slide that we put on, it's about for us to all learn. And by no means am I coming here and saying I'm an expert, because I'm not. I'm learning just like everybody else on the call. And I think one of the reasons we selected a paper is because we haven't so far in the team done a piece of work that's been kind of focused on communities here, or had that kind of thinking from, to be inclusive. So I think moving forward and thinking about our plan for next year and kind of future projects, it's definitely something that we've talked about outside of this conversation, because we've had to select a paper that not only wasn't kind of local, was from it was from the USA. So thinking about, okay, so what can we do? So it's definitely it's having those conversations and having those thinking moments. So yeah, I think it's been a process in itself preparing for today, definitely.
Thank you. Rose?
I was trying to type it in the chat, but I couldn't get my words right. It's just going back to the letter that Justin was talking about and the toolkit in general. So my partner's trans, so I know quite a bit. And I'm aware that some of his medication that he takes, such as testosterone, affects things like his bone density. And for trans femme people, that it can affect their muscles. So that could be why it was included in that letter, because actually these things do take an effect, specifically medication. And just for the toolkit, I was on TikTok, because I am from that generation, the other day, and it was a doctor discussing how actually when they get a blood sample and people have changed their gender on the NHS to like male, female, whatever they assign to, actually sometimes the tests that they need to do are skewed by that. So like not sugarcoating and actually having the correct gender at birth is sometimes really important to certain things, because otherwise some tests just don't make sense, if that makes sense. And I
Thank you for
think
sharing.
the understanding of that is very important, because actually sometimes these things can come off as actually this is all we're talking about, but it does impact what is going on.
Yeah, thank you. And I think it's a lot to do with when and where the right times for information to be shared, and how. I mean, hopefully, particularly with the data sharing that we've got with the NHS and the new NHS platforms and the way that we're now sharing information, it'll make it far more practical in the way that we share information, particularly between medics and clinicians and between places, but also between industries as well, so that people can have that information, like the letter shared, where it doesn't need to go into as much detail, but then they can still access the rest of the information on the platform or on their systems as well, so it doesn't become that kind of focus away from the situation. But of course, it is important that they have the full picture of their medical history and their data sets as well. And I think just Justin put a bit more information into the chat around that situation as well.
I wonder if it's about just having those standardized approaches, like, having collaborative work done, having a template, what a letter could look like, or any kind of communicative piece of work. It'll be a process, nothing happens overnight, but having that collaborative approach, and then being able to cascade that once, you've got something in place, and then it's just second nature. We know what to expect. Practitioners won't know what to expect, patients know what to expect, regardless of the, and but it's starting that work, I guess, isn't it, to get there.
Definitely. And there is a lot of interesting information out there at the moment. I mean, there's an organisation called XYZ that have done a education video working with NHS and staff, nurses and clinicians and public health professionals. And they focus on this, how you can use language, how appointments and the experiences of trans and non-binary people accessing GPs, accessing gender services, accessing hospital services, and the challenges that they've experienced in doing so. And they've done it in a quite creative way. So I do encourage you to have a look for that organisation. I will try and put it into the chat, actually. I think there we go. So yeah, there's a fantastic video on there, and they go into some of the experiences. And I think it is about us sharing those experiences of the trans community and the non-binary community in an authentic way, and then having how we learn and how we move forward with that. Which is hopefully, the point of this conference. There's lots of different types of sessions happening during this conference throughout the month. We're doing a session around inclusive language. The community health profiles is in the last week, which will be exploring the health needs of our trans population, bi plus, gay, lesbian. But I'm also doing the health inclusion session as well in that final week, and also many more. So do check out the other sessions, and hopefully we can see where things can start to slot together, and we can start to build and learn from this opportunity. Any other questions or anything that anybody would like to raise? No? Okay. Thank you, Aisha, and thank you for opening the conference and starting us off in a fantastic point, and hopefully opening the question around learning more around health literacy. Do check out the Healthy Brom YouTube account. There is a health literacy measurement toolkit, if I've got that right. Lauren can correct me if she's still on the call, that the behavioural science team did a few weeks back. So that goes into more detail generally around health literacy. And if you can complete the evaluation form, so I know it might be a bit further up in the chat, but it will be going out in the emails afterwards. So if you can complete the evaluation form so we can learn more about what we can improve as the month goes on, but also how we can showcase the value of doing these sessions like this. But also, if you want to get more involved by submitting an e-poster or hosting a session, you'll be able to find the web links in the chat to find out more about how to do that on the conference web pages, and also all of the different events. We've got over 21 events planned in for the month so far, so you can access all them at the Eventbrite collection. Thank you, Lauren. And Lauren's put in the chat the link to the other playlist that's on YouTube around the measurement toolbox as well for health literacy. So thank you, everyone. I hope to see you at some of the other sessions throughout the month, and I hope you have an amazing week.